Welcome, everyone. My name is Dr. Ben Buchanan. I'm a clinical psychologist and the CEO of NovoPsych, and I'm absolutely thrilled to be hosting tonight's webinar on assessment and treatment of eating disorders. Here at NovoPsych, we love running these sessions because it gives us a chance to connect with the people who use NovoPsych. And tonight or this morning, depending on where you are in the world, we're expecting 1,000 people, psychologists, psychiatrists, counsellors, social workers, dietitians, CBT therapists, GPs, and mental health professionals who are passionate about improving care and who know that high quality assessment is an important part of that. The huge interest we've had in the webinar, I think, is testament to the mental health community's commitment to continually building skills to better serve our clients. At NovoPsych, we provide a range of psychological measures, and I know that many of you use these cool tools. We've got over 150 psychometric measures, some of which we'll talk about tonight. Tonight is an opportunity to learn how we can do a better job at identifying eating disorders and ensure that our treatments are evidence-based. And what's really exciting about tonight is our wonderful presenter, Professor Tracey Wade, who has devoted her career to ensuring that eating disorder clients receive high quality care. So it's my great pleasure to introduce Professor Tracey Wade, who has worked as a clinician in eating disorders for 30 years. Her current research interests focus on the etiology, prevention, and treatment of eating disorders, with a strong emphasis on translating research into real-world settings to improve outcomes. She has co-written 4 therapy books and has over 300 publications in peer-reviewed journals. I must say that's a bit intimidating and probably more than many of us have read. She's actually been a contributor to 300, which is pretty amazing. She's the director of the Flinders University Services for Eating Disorders and the Blackbird Research Initiative. Professor Wade served as a president of the Eating Disorder Research Society and is currently a senior associate editor for the International Journal of Eating Disorders. This year, she was honored with 2 prestigious awards, the Academy of Eating Disorders Leadership Award in Research and the Australian and New Zealand Academy of Eating Disorders Lifetime Achievement Award. And I must say, Tracey, that is a well-deserved award. Welcome.
Thank you very much.
And so, Tracey, before I hand over to you, I wonder what inspired you to devote your career to eating disorders?
It happened when I was doing my Master of Clinical Psychology training, which I did in Canberra. And I had a 3rd and final placement at the counselling service at the Australian National University. And one of my supervisors said, "Oh, we don't see many people with eating disorders, but perhaps we should run a group and see what happens, see who turns up." And in the end, they got so much interest, they had to actually run 2 groups. And I attended those groups and supported the lead therapist. And I guess what really struck me and captured my passion at that time it was all women, and we're well aware now that it's not just women that have eating disorders, but these were university students who were female, who were very bright, were very personable, but they completely believed that they were worthless because of their weight, their shape, and felt that a way to feel better about themselves was to control their eating, their weight, and their shape. So, yeah, I guess I was just amazed that these people just couldn't see what I could see, which is that they were great, and all they could see was that they weren't good enough. So that really inspired my passion to work with people, because I could see that they were missing out on a lot of really important parts of life because they were hiding themselves away.
That massive discordance between how they saw themselves and perhaps the reality of the situation. And that spark has led to, 300 publications and a few books and things like that.
Yep. So yeah, the next job I got was working as a therapist at Cambridge University in the eating disorder clinic. So that was me for life. I was sorted.
All right, very good. And found the passion pretty early on. So Tracy, I'm going to pass over to you.
Okay, thank you very much. I'm going to share my slides. Okay, so thank you everyone for attending, probably at a time that is either late or early in your day. And as Ben said, we're going to take a bit of the broad overview here. We're going to take the biggest perspective and not head down into too much detail. So there's three topics that I'll be covering over this next hour. The first is talking about assessment. And within that, I'll be looking at screening tools, self-report, diagnostic interviews or tools, and just a footnote on making the most of assessment and why that's important with people who have an eating disorder. Then I'm going to look at the overview of evidence-based treatment approaches, what is recommended by the treatment guidelines, what sort of outcomes can be expected. And this gets divided across different eating disorders and also across age groups. The approaches are different. And finally, I'll end up talking a bit about monitoring progress. And Ben has already talked a bit about this and why it's important, but how to do it, what to use, how to do it, that's equally as important. And Ben is then going to pick that up a little bit more after I finish talking. So let's think about assessment. Let's particularly think about screening tools. So before you even want any great detail about people's eating, it's worth knowing whether eating is a problem for them. So I'm just going to look at the reasons why people should screen. First of all, eating disorders are prevalent. Now, if I was doing a workshop without hundreds of people on it, I might ask you to tell me what you think the prevalence of eating disorders is, and we could look at the different answers. But I'm going to cut to the chase, and I'm going to tell you, going to give you the answer here. So first of all, 82% of eating disorders emerge before age 25. But at that point, we know that 18% of females will have met criteria for an eating disorder, almost 1 in 5. And 2.4% of males will have met the criteria for an eating disorder. And we know that people of different genders, particularly people who are binary, trans, also have quite high levels of disordered eating and eating problems. So this is not a problem that I guess affects a minority of people. And yet when I present these population-based statistics, people are often quite surprised. They think it's a much lower prevalence. And when you read the literature, people often talk about it as a low prevalence disorder. So I guess my first main point here is it's not low prevalence. The thing to watch out for is that unless you ask, people might not tell. So what can you expect? What's the breakdown? You can see here, and I'm just looking at females, 6% will have met criteria for anorexia nervosa, 2.5% for bulimia nervosa, 0.6% for binge eating disorder. And that's a disorder that tends to emerge a bit later in life. And then quite a few people, 4.5%, meet this other specified feeding and eating disorder called OSFED, and another 4.5%, the unspecified feeding and eating disorder. They're both unfortunate names because they sound like they're just sort of the throwaway categories. It's really important to realize that the impairment that these people experience is the same as the other eating disorders. meeting the diagnostic criteria of anorexia nervosa, bulimia nervosa, this is not what tells you about impairment. It is similar across all the eating disorders. And you'll notice as I talk, if I've got a yellow box on my slide, it gives you some of the references if you do want to chase them up and have a look at those. So the OSFED are made up of different types of disorders. The atypical anorexia nervosa, this is people that have lost a lot of weight and are actually medically compromised, but they're not underweight. So they often get missed because people think, oh, it's great, they've lost weight. But no, it's not great. These are people that are very medically unwell. They can end up in the emergency department. They're very preoccupied with food and eating. Purging disorder and the lower frequency bulimia nervosa and binge eating disorder. Okay, the second reason to screen is that eating disorders have high levels of comorbidity. So if an eating disorder exists, you can expect a variety of comorbidities. So it helps you to start to look for things, to expect things, and to really, I think, be able to ask the right questions of your client. So what sort of things do we expect to see? We know that the most frequently co-occurring DSM-5 diagnoses are mood and substance abuse disorders. And anxiety disorders are also affecting about half of our cohort. The other thing to watch out for that's very comorbid with eating disorders is suicidality, suicide attempts, and self-harm. We think that self-harm occurs in about 40% of our clients. So if you are detecting an eating disorder, you really need to then ask about the other things that might be happening. So in addition, of course, to the co-occurring diagnostic disorders, there are other common comorbid features that you will expect to see: affect regulation difficulties, negative affect, perfectionism and obsessionality, cognitive inflexibility, impulse control difficulties, deliberate self-harm I've mentioned. We also are becoming increasingly aware that neurodivergence is very comorbid with eating disorders. And so that's becoming a greater focus as well. And we know that around 2/3 of people receiving treatment for an eating disorder do experience at least one traumatic event. They may not have PTSD, but they have certainly experienced trauma, and that can affect the way that they see the world and their place in the world. The third reason to screen is that, and I've hinted at this already, eating disorder symptoms are commonly minimized by people. So we know that the minimization of symptoms is actually the biggest predictor of people not seeking help for an eating disorder. So it goes like this: I don't believe I have a problem, or it'll get better without help. And so you really have to get eating disorders about, why it is that people don't see it as a problem. So it's a bit different from things like depression and anxiety. People do see that as a problem. But in the early phase, particularly, disordered eating has become the solution for people. It's a structured and predictable refuge that creates a sense of control, perhaps security. It simplifies the problems people might be experiencing, and it reduces the complexities of life to that number on the scale or that number of calories that people eat in a day. The other, I guess, very reinforcing thing about eating disorders is that it can win admiration from other people. People will often in the early stages make comments about, oh, you've lost some weight, you're looking better, that clothing fits you better. And these comments can come from health professionals. And particularly, again, this group of people with the atypical anorexia nervosa, as they start to lose weight, people will be saying that that's a good thing. We also know that being on strict diets can win admiration, being vegan, being a clean eater, all sorts of things that people get rewarded for. So there was an Australian study done by Philippa Hay, and it found that GPs who asked about a person's mental health rather than diet or eating, this was actually more likely to result in a mental health referral for people with eating disorders. So if you start to screen, if you start to ask the questions, people will start to talk about it. But if you don't ask, they won't tell. So that's why they might be presenting for depression, but there may actually be a major eating disorder there that they're just not talking about. So that's why screening is so important. And finally, the reason to know if disordered eating is there or not is because it interferes with therapy. If people have a malnutrition brain, and they don't have to be underweight to be malnutritioned, so they can be in a normal weight or be in a bigger body, but still malnutritioned. And that does significantly interfere with therapy. And it also interferes with people being able to learn new behaviors, which is exactly what we need them to do in therapy, even if it's not therapy for an eating disorder. So it's always worth checking about your client's eating and giving them some basic psychoeducation if they don't have an eating disorder, just about what I call functional nutrition. And this is just having sufficient nutrition every day, enough complex carbs that can aid in brain neuroplasticity. Good nutrition helps with the formation of new connections between neurons in the brain so people can learn. And importantly, what we eat is also incredibly important for our epigenetics, which is the environment that helps our genes function in the best way that they can. And it helps the genes express themselves. It doesn't, of course, remove genes, but it helps the expression of the helpful expression for genes. And also, of course, it gives us energy. It helps the gut stay healthy, which adds to emotional regulation. So just a basic checking of eating before you go ahead with therapy is important in order for the person to get the most out of therapy. Okay, so all of that said, what are the most important screening tools? Well, through your contact with Novopsych, you might have come across the eating disorder examination questionnaire, and that has been made into shorter versions to make it suitable for a screening tool. And I've given you a web link there where you can find one of those shorter tools. There's an eating disorder screen for primary care, a screen for eating disorders. Many of you would have heard of the SCOFF, which stands for Sick, Control, 1 Stone, Recent Weight Loss and Fat and Food. And the Inside Out Institute has just developed a new screen, and I've given you the web address for that. So an example of one of these, the screen for disordered eating, is on your right. Do you often feel the desire to eat when you're emotionally distressed? Do you feel you can't control what or how much you eat? Do you sometimes make yourself vomit to control your weight? Are you often preoccupied with the desire to be thinner? Do you believe yourself to be fat when others say you are thin? So the issue with screeners, and the reason I'm not a great fan of SCOFF, so it's a very old measure, and it doesn't map on to the newer eating disorders that we have been recognizing over the last 10 years. So I guess the issues to consider when you're choosing a screening tool is that basically that most of them are good enough, but I would go for the more recent screening tools because they have been devised in order to recognise the broadening of our eating disorders that we see now in practice. And just as a footnote, language is important. There are no screeners suitable today for Indigenous peoples. So this is a particular note to our Australian listeners. But we are actually currently working on developing a screener with young Indigenous people in Western Australia. And that seems to be going quite well. So I would say watch this space. I would hope within about a year we would have a screener for Indigenous young people. Okay, self-report questionnaires. So again, you would be aware of some through your contact with Novopsych, and I'm just going to mention a few of the more commonly used tools. So we've already mentioned the eating disorder examination questionnaire, and that's freely available and is one of the most commonly used self-report tools. But there are a lot of others. There's the binge eating scale. The body checking questionnaire is quite good if you're working with someone with an eating disorder and you're wanting to move into that type of work specifically. That's a good one to start with so you can see where the actual problems are. And there's also the body image avoidance questionnaire. And with eating disorder clients, they can be doing both. They can be checking their bodies, but they can also be avoiding looking at certain aspects. So it's important to have a good sense of what's going on with those behaviours. This is a component of cognitive behaviour therapy to work with the body image. It comes a bit after the refeeding, the renutrition. So when you're up to that work, those are good questionnaires. I also really like the body image acceptance and action questionnaire. It's quite short, but it picks up on people's ability to it's a little bit like the degree to which they judge their self and how their life is going according to their weight and shape, or whether they're able to now step back from that and separate themselves a bit from that tyranny of weight and shape in terms of its impact on self-concept. So when that starts to improve, then you know that your therapy is having an impact. The body shape questionnaire has been around for a long time. So again, that is useful when you're starting to work on that area. The clinical impairment assessment, again, it's part of what you can access through Novopsych, and this is looking particularly at the eating and its impact on quality of life. And this is a nice one because clients don't like us asking about eating all the time. This is one that recognises and helps the client to recognise that wider impact on social relationships, on ability to focus on other people, ability to work, ability to get things done that they value. So that's a nice one for that broader picture. The Dutch eating behaviour questionnaire, again, has been around for a while and picks up a lot on restrictive eating. The eating disorder diagnostic scale is very similar to the EDEQ and would have generally less validity associated with it. The eating disorder questionnaire, again, looks at a variety of components, domains of people's life. And it might be of interest, the night eating questionnaire. This is something that you can certainly find in some clients, that they go to sleep, they'll wake up and they'll start to binge. And that obviously can impact the type of treatment that you're offering. And so that if you think that that might be happening, that would be a good tool to use. We're going to talk about the ED15 at the end, so I won't spend time on that now. Okay, diagnostic tools. What have we got? If you actually want sort of an official diagnosis for your client. There are actually various free diagnostic interviews that are available. So you have the eating disorder examination. You've got CAMX, which is a German tool. So if we have anyone listening from Germany, then that may be something that particularly suits you. The one that we use in my clinic is the eating disorder assessment for DSM-5. So the reasons we use that is because it's been updated really nicely to map onto DSM-5 for that broader range of eating disorders that we are seeing. So it does pick up, it's online, so you can do it on your phone or iPad or whatever it is that you've got in your consulting room. It's easy to use. The clinic, the eating disorder clinic that I run, is basically the trainees are the therapists and I supervise their work. So the trainees are using this and they find it easy to use, and it really helps them to narrow down the type of diagnosis that's presenting, or to know what questions you ought to ask to make that a bit clearer. One eating disorder or feeding disorder that I did want to highlight, and I want to highlight it because it's, again, it's relatively recently recognized. It's been around for a long time, but with the DSM-5, it came into greater focus. And it's called avoidant restricted food intake disorder. ARFID, you may have heard of it. It's basically an apparent lack of interest in food, avoidance based on sensory characteristics of food, concern about aversive consequences of eating. It's one of those three. It doesn't have to be all three together. And so it's also not connected to body image or weight and shape concern. So that's why we call it really a feeding disorder. And you will see it emerge in quite young children. But you can have adults presenting who have never been diagnosed, but are presenting with these symptoms, but were never diagnosed. So I did want to mention this because it's something that people are coming into treatment for more and more often. And it can be fatal if people, particularly kids, are not eating enough. Then we do hear occasionally of people dying, or children dying because of this disorder. So, but it's also something that puts a lot of strain on the family, with children who are not eating, who are not able to go out for sleepovers because they can't eat the food. They get very anxious and distressed. And of course, again, it's very comorbid with the autism spectrum and neurodivergent. So it's often there are some comorbidities that go with this. So if you think that might be what you're seeing in the clinic room, then there is an interview, the party, or there's a self-report measure. And I've given you the website for that. And parents can answer it, or if the child's a bit older, 14 years and over, they can answer that. So here's an example of one of the categories of ARFID. Over the past month, have you avoided eating situations because you were worried something bad might happen, like being sick, choking, having an allergic reaction, or being in pain while eating? For example, because you might be served something you usually avoid, or because you've had a bad experience in the past. So this is happens typically perhaps when children have experienced something a little bit traumatic with swallowing. They might have choked, they might have had a medical procedure with a tube down the throat. So this is more of an anxiety reaction, which is different from the sensory issues, which again is different from just, I'm just not interested in food. It doesn't float my boat, which most of us don't understand. So this is well worth being aware of. And I've also just given you in the orange box, if you have got clients like this. There are two of, I think, the best resources we have to date. The first one is by Rachel Bryant-Waugh, who's a very experienced child clinician from the UK. And she has an ARPID, a guide for parents and carers. As I said, it can take a toll on the family as well. So I think that's a really helpful resource to be able to suggest to parents and carers. And also Jenny Thomas and Cameron Eddy's book, A Cognitive Behavioural Therapy for Avoiding Restrictive Intake Disorder. So that is a book for therapists, and that just steps you through those 3 different presentations of ARPID and the protocol for working with that within a cognitive behavioural therapy model with children and with adolescents. And of course, it can be adapted for adults. Okay, I want to talk about making the most of assessment because of this issue that I've already talked about, which is that people are quite ambivalent about whether they have a problem, and they're ambivalent about giving up all of the eating disorder, the bits that have been working for them. And there's a very strong fear in a lot of the clients that you see that therapy will make them gain weight, but also make them gain weight uncontrollably. And so it's quite a frightening experience for people to come in and even think about therapy. And so that's why at assessment, you really have to get alongside of your client and really not just instill hope, but let them know that you get it, that you understand what's going on. Probably quite a few of them, when I've talked to other people, might have been told just to eat, or to stop being silly, or to stop being so worried about how they look. And they have felt disregarded, they have felt misunderstood. So the assessment is not just a time for getting information, it's a time for conveying a lot of important information to your client about the fact that you can stand by them and work with them and that you get it. So you do need to consider the motivational issues that are part and parcel of the eating disorder. And we often talk about the eating disorder voice, which is essentially yelling in the person's head, get out of the room, this person's going to make you fat. So you've got that competition when you're doing an assessment. And for this reason, I advocate the use of a motivational enhancement style throughout assessment. So most of you are probably very familiar with motivational interviewing. So we're talking about using those skills, not just to conduct assessment, but throughout therapy, whether it's CBT or whatever the modality is. This motivational enhancing style needs to be present at all times. So it's an attitude of respectful curiosity pertaining to the patient's perception of the problem. You're using the techniques such as talking less than your client does, a greater reliance on open than closed questions, using reflections, using complex reflections, not asking 3 questions in a row, and avoid getting too far ahead of your client's level of readiness. So that curiosity, those double-sided reflections, on one hand this, but on the other hand that, can you help me make sense of this? This is really critical stuff to keep the conversation going. And you're really wanting to get the client to help you understand the functions of the eating disorder for them, but also what's not working now, or what's changed, what's stopped working. How is the eating disorder actually ruining their life? How is it making their life unenjoyable and quite and being quite a barrier to them getting on with their life. So a lot of my clients, the younger clients, will say, all my peers have got on with their life, but I haven't been able to. I'm stuck. So it's also having time in your assessment to consider the benefits of change and the barriers to be overcome, to think about, to instill hope, because people have come to you, often they've tried many things to stop the eating disorder, but often that's been about thoughts about today I'll be successful not eating as much. But they often feel they've failed and they've failed and they've failed. So instilling hope, incredibly important, and envisioning a future that's guided by their key values and their future goals. Now, I've mentioned this advantages of change, this thinking about this. This is a worksheet that we get our clients to go away with after assessment. And then we pick it up with them in our meeting after that. This is something that one of our clients completed. It was a male client, and he could see many advantages of change, getting better food and being less focused, less obsessed about food, which would free up his mind to focus on what really matters. Less shame, less guilt, exercising for fun, not for weight control, and feeling more visible or feeling less like needing to hide one's body, just being more relaxed about being who you are. Being more open to others, feeling less lonely and less physical and emotional pain. But put this side by side with the fears of change. Let's capture that ambivalence on one page. This means that this person would have to give up this hope of losing weight, even though they had recovered from anorexia nervosa. That was still a goal. That they won't be able to maintain changes. In other words, that they won't be successful. This is another thing that they'll fail at. Therapy is another chance to fail, to not be successful. And the real fear that none of this will fix anything. I'll do all this, but I might find worse ways of coping with stress, guilt, and shame. So these are very potent and real fears. And then we ask the client to think about responses to the fears, and in this way, to something they can go back to, particularly at those really difficult moments. And this person talked about working on their skills. It's not about fixing anything, it's about stability. Maybe I will find less harmful ways to cope. And I have been successful if I set my mind on things. I think I can do this here. And then we ask people to develop a summary statement, particularly, again, something they can use when things get tough. So this person said, despite my fears, I have made changes in many areas of my life. I could choose to rinse and repeat, or basically keep doing what I'm doing, or to make changes. In comparison to giving up drugs, alcohol, and self-harm, doing well at university, then working towards stable and healthy eating and exercise is likely to be achieving and likely to be liberating. So that message of hope to spur them on in the difficult moments. The other thing that's important is to develop that collaborative understanding of the eating disorder over your assessment. The fact that it is a vicious cycle, it perpetuates itself, and that's why it's so difficult to break out of without help quite often. And of course, you can make this specific to the person. But I think it's important to realize there are valued aspects of disordered eating, the restriction, which represents personal characteristics, the characteristics of control and of strength. And people admire people who can diet and lose weight. That's a societal sort of message that we get. There's also then the biological impact of restriction. We know that dietary restriction has a very quick impact on, as I said, the brain, our genes. It increases denial, rigidity, anxiety, depression, withdrawal, and obsessionality. So the actual symptoms of the disorder start to cement in the disorder. And of course, the behaviors that embed the eating disorder can cause changes to family dynamics, social withdrawal, disconnection from previously valued domains of life, so that the eating disorder becomes really the primary companion of the person, the predominant force. And people also then find that their identity is merged more with the eating disorder. They talk about it as a companion or a friend, and their identity becomes increasingly synonymous with the eating disorder. So it's worth recognizing this type of cycle. The other just quick hint I want to give you, and this is based on research that we've been doing over the last couple of years, is give the patient something to focus on between assessment and treatment. Just don't do the assessment. We give them that worksheet that I've just gone through, but what we also give them is a single session intervention. And it's a single session intervention of behavior activation. And it's been what I would call infused with functional nutrition, but basically it's your SSI based looking at behavior activation, the behavior activation we all know and that we all use. And that SSI is available on our website. I've given you the website there. It's a PDF. You can download that for free. So if you want to have a look at that, please feel free. But in our most recent publication that's just come out, we found that the use of this SSI between assessment and before treatment starts actually meant that 64% of our patients in our eating disorder clinic significantly decreased dietary restriction before treatment even began. And this is really important because decreasing dietary restriction is the first step in cognitive behavior therapy. And we take up about 4 sessions to work on it. If people don't have anorexia nervosa, it takes longer if they have anorexia nervosa. But it means that people are starting to respond early, and that's actually a good prognostic indicator for a good outcome in treatment. It's also just so incredibly important. People have some immediate step they can take to break out of this sense of failure and not the feeling that the eating disorder is now controlling them. So it can be quite simple. And even giving people psychoeducations, just some basic information, research that was published last year found that giving people something in this time before treatment, regardless of how simple it is significantly more likely to lead the person to complete treatment than if they get nothing while they're waiting for treatment. And we just have a 2-week or a 4-week break between assessment and treatment. I'm not talking about a long period of time, but giving them something as opposed to nothing means that they're 3 times more likely to complete treatment. So think about that and think about your practice and perhaps play around with this bit. Okay, now we can come to treatment and outcomes. So I'm going to start with the overview here, and then I'll talk about some specifics. So the overview is that basically disorder-focused psychological therapies are the first line of treatment for most eating disorders, and medications have a mainly adjunctive role. And you can expect the remission rates from therapies to be somewhere between 30 to 60% of these psychological therapies. I'm going to talk a little bit about medication here, and then I'm not going to mention it much after this, but antidepressants are not particularly effective when people are underweight. So even if there's a comorbid depression, it doesn't it doesn't cause that great change that you're looking for with people with anorexia nervosa. And indeed, we have to be careful about medications when people are very underweight. There is a history of people using low-dose olanzapine, which is an antipsychotic, to support weight gain in adolescents or adults with anorexia nervosa. The problem, it's often used more in an intensive treatment setting, inpatient, day patient, just to take the anxiety off before a meal. The problem with olanzapine is getting people to stay on it. As you would know, one of the side effects is weight gain and problems with potential development of diabetes. And the impact on psychopathology is less clear. We just don't have good randomized controlled trials which help us understand how useful olanzapine is. Now, pharmacotherapies for bulimic disorders are a little bit more effective, particularly fluoxetine or SSRIs, the antidepressants, as adjunctive treatments for bulimia nervosa or binge eating, or bulimia nervosa in particular, because they do seem to have an anti-binging effect. You've also got, I can never pronounce this when I'm under pressure, but the dexamphetamine and topiramate for binge eating disorder. Now, it's a bit too early, and also now we've got our GLP-1 receptor agonists. There have been a couple of very strong publications in the last 2 years looking at both these in people who are in a bigger body that have disordered eating and eating disorders. And the results show that it can lead to some weight loss and doesn't cause any problems with the, it also helps reduce the eating disorder, but it's very early days. So my general summary about medication is that it's early days, apart from perhaps SSRIs with bulimia nervosa in particular. Now, when I'm presenting this overview and talking about treatments, I'm very much guided by the NICE guidelines. People from the UK would be very familiar with these guidelines. We have Australian guidelines, there are American guidelines, but and they all say much the same thing, and we have German guidelines. Every country has their guidelines put together based on the evidence, but I'm particularly, I guess, impacted or influenced by NICE. Okay, let's look at the specifics of eating here. So first of all, if you're working with an adult and an eating disorder that is manifested by binge eating, which could be bulimia nervosa or binge eating disorder. So you'll notice I've got SSRIs up here. We've got a moderate degree of evaluation and they have a moderate effect. Now, of course, in and of themselves, once people come off them, people will relapse, which is why we recommend their use as an adjunct to one of the therapies that are recommended, particularly cognitive behavior therapy. You'll see cognitive behavior therapy is next on the list here, both guided self-help and more full-on therapy. The other thing, you'll notice that there's been certainly a moderate degree of evaluation and substantial effect. The other thing you'll notice here is that I'm referring to CBT-ED. I'm not referring to a specific brand of CBT for eating disorders. I'm just talking about generically a cognitive behavior therapy that's been put together for people with eating disorders. There are specific brands within that. So most of you would have heard of CBT-E, CBT Enhanced. My colleagues and I have developed CBT-T, CBT-10 for people who are not underweight. So there are different versions of CBT that overlap, that have similarities but differences. Now, IPT stands for interpersonal psychotherapy, and this has had some evaluation and has substantial effect. And I've got psychodynamic psychotherapy there. It's had some evaluation, but there is no evidence for effect. So I'm just going to unpack the last two there, just so you can understand what I'm talking about. This is, first of all, cognitive behavior therapy versus interpersonal psychotherapy. And this is the remission rate. This is work from Christopher Fairbairn, and across two different trials that he did with his enhanced CBT. And he also used IPT as a comparison. And it was actually while I was a student at ANU, but the thing that I mentioned right at the beginning of this talk, someone came out from Chris's lab to talk to us at ANU and talked about this, the first study. They'd actually chosen IPT as a placebo. They thought that people wouldn't get better. And IPT, of course, has been put together originally for depression. It is psychodynamically informed, but it focuses on the here and now. It focuses on helping people strengthen their interpersonal functioning. It has a manual. It's very structured in a lot of ways. What they found was that IPT does have a substantially helpful effect on disordered eating in people with bulimia nervosa, but it takes longer to have an effect. You can see that blue line down at the bottom. Session 20 is when therapy finishes. And what IPT does is people still get a bit of benefit over the 60-week follow-up. The beginning to end of therapy, you can see there's a big gap there. That's a significant gap. IPT doesn't look as good. It starts to catch up with CBT over time, over the 60-week follow-up. So that's good to know. Not everyone can do CBT, but you also need to understand and be able to explain to your client that it takes more time, and it's just a more gradual effect. Now, I said psychodynamic therapy is not indicated with binge eating disorders that have binge eating. Excuse me. And this is work I actually saw presented. I think it was, I think we were in the US, and the presenter, who was Paulson, was from a psychodynamic group. They got Chris Fairbairn to train them in CBTE. So they were very passionate about psychodynamic psychotherapy, but they were less skilled in doing CBT. What they found in terms of the percentage of people who ceased purging and binging was that they had the immediate drop by the end of therapy, the blue line, in terms of the number of people binging and purging, and that was maintained at a 2-year follow-up using CBT. And what they found, though, with the psychodynamic, which is the orange line, is that about 15% of people ceased binging and purging over the 2-year follow-up, but it was a significantly worse outcome. And remembering that the CBTE was 20 sessions over 5 months, the psychodynamic were weekly sessions over 2 years. And that's why there was a 2-year follow-up. So the people received in the blue line didn't get any therapy after 5 months. People in the orange line were getting weekly therapy. So that is why I would not recommend psychodynamic therapy for eating disorders that feature binge eating. But there is a but. With adults with anorexia nervosa, focal psychoanalytic therapy is on the list. So this is why it's really important to understand the different therapies that are indicated for the different disorders, and to make sure that you understand which is recommended and which is not. So with anorexia nervosa with adults, it is our biggest challenge, because the thing that we know is that doing something is better than doing nothing. The reason we know that is because in 1990, Arthur Crisp in London published a study where he actually did randomize people with anorexia nervosa to get nothing over 12 months. And he had 3 other conditions where people got something. The something would not be considered necessarily best practice today, but one of the somethings was inpatient therapy, people becoming inpatients for quite a long time. And the 3 active groups, the other 2 groups were outpatient therapies. The 3 active groups, there was no difference between the 3 in terms of outcomes, but certainly people did significantly better than doing nothing. Now, ethically, we can't do those designs anymore, and we should not be doing those designs. There is a general consensus of the need for specialist care with this group, and it should include both nutritional rehabilitation and weight restoration, in addition to psychotherapy. So this is where this group may be need some intensive therapy in an inpatient or day program or residential setting, or it might be something that can happen with support of others in an outpatient setting, or some people come in ready to change and can do this as an outpatient. So what is the psychotherapy that we're talking about? It's CBTE, has been looked at specifically. Focal psychoanalytic therapy, there's only one study that's been conducted, and it was in Germany, where the therapy was devised. Interpersonal psychotherapy is not recommended. So again, this is where what works for one eating disorder doesn't work for another. There is no evidence to suggest that this should be used with anorexia nervosa. Refeeding or dietetic advice alone, again, is not recommended. What we see is that people relapse. It's certainly an important component of therapy, but not isolated from psychotherapy. Mantra was developed again in London. It's the Maudsley anorexia nervosa treatment for adults, something like that. There's good evidence, and there's also good evidence for specialist supportive clinical management, SSCM. And that, I don't have time to describe the different therapies to you, but you can certainly find these online. You can find papers and in some cases treatment manuals or access to descriptions of these therapies. I did want to just also show you the outcome from the trial that we did in Australia with adults with anorexia nervosa. And the graph there is showing how many participants achieved a healthy weight at each time point. The first time point is where they started, then midway through therapy, at the end of therapy, then 6 and 12-month follow-up. You can see CBTE, there were 50% of people who attained a healthy BMI, and it was just under 30% for the other 2. So that is, I guess, persuasive. However, when you look at remission, which means not just weight, but disordered eating and an acceptable reduction in disordered eating, then it starts to change around. You can see that both SSCM and CBTE achieve the most there. We didn't get quite that response with Mantra. Mantra works best in the UK, where it was developed, where the team have more expertise. So that needs to be taken into account. So the general conclusion is that CBTE may be better at helping people put on weight if they have anorexia nervosa, but there's really no clear differences in outcome between these 3 therapies. So any of the 3 can be used responsibly, and it's something we need to do better. We need to figure out well, we need to get better outcomes. We need to figure out which therapies are better for who. Okay, let's move on to children and adolescents. Family-based treatment, of course, is the dominant treatment, and it emphasizes the active involvement of parents in the recovery process. Basically, they take the burden of the therapy. It allows young people to receive treatment at home, and but it's costly. It can require parents to give up employment for a while. Caregivers need to be robust. They need to be able to agree on strategies and work collaboratively together, and really join against the anorexia nervosa. It does not work for everyone. It works well for about 70% of people. And there are some concerns about a lack of a clearly defined way of handing over autonomy to the young person. What about children with bulimia nervosa? So that's family-based therapy generally, because this will come up. Children with bulimia nervosa, randomized trials have compared family-based therapy with both CBT, guided self-care, and supportive psychotherapy. And this is my personal interpretation of looking at these results. I would say that cognitive behavior therapy is the preferred treatment with this eating disorder. You get more rapid reductions in symptoms, and it's more acceptable. Kids don't want their family involved, particularly as they are older adolescents. But there are differences of opinion in the treatment guidelines. Some would agree with me, some would suggest family-based therapy. So that's the one area where the guidelines are most likely to disagree. Children with anorexia nervosa, FBT is certainly the treatment of choice, but just realizing that 22 to 42% of kids have poor outcome at 12-month follow-up, so it's not the magic bullet. And there are various versions of FBT. There's parent-focused and multi-family group therapy, which are also useful. And there's a modified family-based therapy for older people, for emerging adults. And that means essentially that you reduce the dropout from therapy if you get the family involved, but the outcomes are the same as CBT. I want to point your attention to a non-randomized trial where families had the choice. They could choose FBT or CBTE. This is an American clinic. And they found that the people that chose CBT, the kids tended to be a bit older and less well. But at follow-up, there was no difference in the groups in terms of weight gain or disordered eating. So CBTE, I think, is a viable treatment for adolescents with an eating disorder. A lot of professionals are reluctant to use it because of that less support from family, a higher possibility of dropout. But it's really nice to know we have an alternative if FBT is not working. Okay, so to finish off, before I hand it back to Ben, monitoring progress. Essentially, it's not just monitoring progress, it's sharing it in session. It's making it part of your therapy. This, the evidence tells us, makes a really big difference in terms of outcome for the patient. So what it requires is using the brief measure. So we ask our patients to fill it out just before they come to session. They can fill it out in the waiting room. It's a brief measure of their eating, and then we look at it in session together with the client to see if the symptoms are indeed changing. What did they struggle with over the week? And it's really nice to graph it. An image is worth 1,000 words. Graphing this with the patient, looking at it in each session. What does this tell us about what you're doing well? And what does this tell us about where the challenges are and where we need to focus therapy? Okay, the reason this is so important is the evidence. We have multiple meta-analyses now, which tell us that doing this collaborative measurement and discussion of symptoms in each session reduces therapy dropout, improves treatment outcomes, makes a below average therapists more effective. They start to actually listen to the client and engage with what's actually happening, rather than assuming they know what's going on. And there's reductions in therapy duration because we're getting better progress. So a very simple thing, it just takes 5 minutes in each session, but you can't afford not to do it because of the substantial benefit it brings to outcome. Just to finish, the ED15 is what we use. Ben's going to talk about this. He showed you the items before. I've got them up here. It's brief. It also has 5 items addressing eating disorder behaviours. It's over the previous week. It's very robust. It's actually much more factorially robust than the EDQ. So we have done work on this and recommend it for the session use. We think it's a really useful tool. And Ben laughed at my slightly primitive way of showing you these results. He's got a much more zippy-do thing that he'll show you in a minute. But this just gives you a bit of an idea about why it's important. You can see here we have a client, if you look at the graph, binging, vomiting, laxatives, dieting, and exercise wasn't part of what they were doing. They all decrease over the first 4 sessions, and you can see the weight and shape concern here is also starting to decrease. But you'll notice at session 5, the binging starts to go up. What's going on? Why would this be? And we can see here that the person's distress about their body shape, their negative comparisons is really staying high. This is not moving. And the client is really fighting against the idea that they can't lose weight. They're worried about their body image and about what people are thinking. So it helps us in therapy to say, okay, these seem to be the issues. Let's direct therapy towards that. Let's personalize the therapy to manage that. Okay, I'm going to finish here and hand you back to Ben.
Thank you, Tracey. That was what depth of expertise you have. And you're right, I did sort of laugh at your slide showing the symptoms, but I think it captures the information beautifully. But I must say, maybe I'm superficial, but I just like pretty colors on mine. So let me, so here I'm going to show you some really practical tips about how you can start using the ED15 in your practice. So here I am on novopsych.com, and I'm going to go into the assessment library. Here we've got a menu of all of the different assessments. And if I go here into the body image and eating disorder assessments, I can pick the ED15 here. So in the ED15, it's a really lovely tool. It takes 2 minutes to administer. It can be used with people 15 years and up. And it has 2 subscales on it, and they are weight and shape concerns and eating concerns. And if you're interested in seeing what the actual questionnaire looks like when you administer it digitally, I encourage you to go to probably just Google eating disorder 15 novopsych, and then press administer now. With administer now, it'll come up with the questions that look something like this. This questionnaire considers your eating attitudes and behaviors over the past week. Please complete this measure by selecting the appropriate answer. I've been a huge fan of routine outcome monitoring for a long time. Certainly for me, as part of the therapy that I provide, I always give questionnaires as an intrinsic part of the therapy session, which really promotes the discussions in the therapy room and keeps the therapy focused on the important things. And so if you were to administer this to a client in session, perhaps on an iPad or on their phone, you can just send a link to their phone. They can just click through these questions. So over the past week, I have been preoccupied with thoughts about food, compared my body relative body negatively to others, avoided looking at my body, been distressed about weight, checked my body um, to reassure myself about my appearance, followed strict rules, felt distressed about body shape, so on and so forth. Then there's some behavioral questions at the end. It asks over the past week, how many times have you binged? And they choose between 1 and 7. Or in fact, with this one, it's much more than 7 because you can binge more than once a day. Um, and this one asks about vomiting. How many days in the past week have you used laxatives? So on and so forth. And so when you get the results, this is what they look like. Um, we we present the results of these two subscales, weight and shape concerns and eating concerns, in this graph. So this graph is automatically outputted. And we actually present it in percentile terms on the first administration. So in comparison to a normative sample of people in the general population, where the average would be 50, anything above the 75th percentile is considered to be a moderate issue. Um, and then we've got severe and extreme ranges. One of the reasons why this can be a really helpful way to present results for the first time is because often people with eating disorders are in a bit of a denial that they've actually got an issue. And so we like to present it in percentile terms so that it contextualizes the results in comparison to other people. And it helps the clinician explain the results. And I think for a client, it's just intuitive to have a score from 0 to 100. Um, and these bands as well. The other things we do with the results is that we not only present a normative percentile, which is what is in the graph here, but also a clinical percentile. So a clinical percentile is comparing the results to someone with a diagnosed eating disorder. And so you can see in this particular example, um, this person scores on the 95th percentile in comparison to the general community. But in comparison to someone with a diagnosed eating disorder, 65, so about average. And that all makes sense. Going down further, these results are automatically plotted like this, where you can see that here is the community median score. So on average, someone in the community will be scoring just above 1. And then clinical median, this is someone with a diagnosed eating disorder, will be between over 2 and up. And then we've got a clinical cutoff here. So this cutoff has been defined using sensitivity and specificity data, where it can reliably distinguish between someone you typically find in the community and when something's a real problem. People often ask, where's that line? What's clinically significant eating disorder concerns, because it is relatively normal, particularly for young women, to have some sort of body image or eating concern. But this can describe and define where that cut point is. If you administer this over time, so let's say you administer it in session number 1, session number 2, and session number 3, it will actually plot the graph over all the results over time. So in this particular example, you can see that eating concerns was the highest. And then in the second session and the third session, that went down a lot. Obviously, this is a sort of idealized example. Not everyone will certainly respond this well. And it wouldn't be uncommon to see people's symptoms bounce around in the severe, extremely severe, and moderate range before they have substantial change. But this graphically representing to this and showing it to the client, it's just a really useful way of having a shared language and a shared understanding with the client about what you're working towards and where they are on their therapeutic journey. And so all of these results, when you administer the ED15 in NovoPsych, will come out as a PDF like this, and you can save that to your practice management software. You can show it to your client, And all of these graphs will be automatically produced. This is an example of the graph that will be produced the first time you administer the ED15, and on subsequent administrations, those automatic graphs will appear for you as well. We've also got a bunch of psychometric properties information. We take great pride here at Novopsych in synthesizing the research that people like Tracey invest so much time in producing, so that we can give really authoritative results on the instruments that you're using. The other really lovely thing about the ED15 is those behavioral questions at the end, where it asked about binges, vomiting, laxatives, restriction, and exercise. And this will provide graphs of over time of how many incidents of those different behaviors the client did. You know, we turns out our human brain is not very good at remembering how the client presented last week, last month, or last year, but computers are perfect at that. And so having an authoritative record of what the client was experiencing when, so you can see when symptoms lift and sort of look back. One thing I like doing is if I see, vomiting lift up, say to the client, what was happening during the week that vomiting increased a lot? And then conversely, if things are really good for a period, looking back and starting a conversation saying, what was going well during that period? How are you feeling during that period? And of course, having these graphs makes those conversations really simple. So that's the ED15 on Novopsych. I encourage you to give it a go. But what I'd like to do now, we've had huge amounts of questions come through while Tracey's been speaking. Tracey, I've picked some of these questions out for you to answer. And I'm going to start with Nikki. Nikki asked, when choosing a therapy based on symptom profile, is this mediated by the lifetime presence of an ED? For example, if someone was to have anorexia for years, but then presents now with binge eating or bulimia, would you choose to target what they're presenting with now or what their history was?
Yeah, good question. If someone has had anorexia nervosa, but have through however they perhaps the body mass index is now in the healthy range, but they have an eating disorder, I always say to my trainees, don't treat them like they didn't have that history. That history matters, because they will be feeling like quite a failure because they've moved from one diagnosis to another. They might be thinking they can get back there. Even when they desperately want to get better, there are regrets and some damage that may not be present in other eating disorders. So without that sort of history. So I think you need to take, so I wouldn't treat it like anorexia nervosa. I treat what you've got, but the context has to be understanding and helping the person get you to understand how they see themselves and how that might impact therapy, and how the therapeutic tasks have to be set up with the person to have the most success, because there will be lots of issues that can interfere. There's more potential for therapy interfering behaviours because of that history. And if the therapist is aware of that, then you can just circumnavigate, you can work with the client and basically get a better outcome.
Yeah. And Suzanne asks, thumbs up or thumbs down for compassion-focused therapy for eating disorders?
Both. So my thumbs up is that I think we usually work at some point in our therapy on self-criticism and move into self-compassion. The issue is that our clients are disgusted about the idea of self-compassion because they see themselves as being so deficient and so unworthy. So we use Paul Gilbert's approach, which is, the compassion-focused approach of the functionality of self-compassion, how it helps you actually achieve your goals more so than self-criticism. But self-compassion focused therapy itself, there are a few studies, few evaluations of it, but there aren't enough for me to say as a scientist that we've got enough data for me to recommend it. But I certainly think the concept's very relevant, and some of that can and should be woven into your eating disorder therapy.
Right. And a related question on treatment modality is there any evidence for EMDR as an eating disorder treatment? I think people are trying EMDR out on everything. What does the evidence say, Tracey?
There are no strong clinical trials of EMDR.
So that's a thumbs down.
That's a thumbs down. If your client, and quite frankly, I'm not quite up with the status of EMDR with trauma. So the related question is, if your client comes in with trauma and an eating disorder, do you try and treat one first, or which one? And the answer is we don't know. The thing we do know is don't try to treat them both together. That just confuses things. Start off focused on one, see what happens to the other. And we consult with clients. We say both these things are happening, and we do have a trauma clinic, fortunately, where we are. Or you can start working on the eating disorder, see how far that gets you, and then you can progress to a trauma therapy. If it seems to be blocking progress, then we might have to change halfway.
Yeah.
So,
and a related question, someone asks, in treating an individual with an ED and depression, would you address the concern of compulsive exercise if exercising is a key component for helping this individual stabilize their mood? Well, that's tricky.
So exercise is great. I'm a great fan of exercise for mood, for health, for all sorts of things, but I am a definite thumbs down on compulsive exercising, because that actually maintains the eating disorder. So we sometimes ask people to completely dismantle their exercise regime and then build it up from scratch to something that's less compulsive, more social, and because you want the benefits of exercise, but sometimes it has to be a dismantling before you can build up again.
Yeah. Got a question here about autism. Do have any of the treatment studies included or excluded people with autism, and how would that affect outcomes?
Yeah, we certainly don't, and we have quite a number of people coming through that identify as being autistic, and studies generally have not excluded people for that reason. But that's not to say that we can't do better with that group. And part of what I'm wanting to do, I've just come back from 9 weeks working at the University of Bath, and spoke with someone who's got expertise in adapting therapies for people with autism. And I think we need to do a little bit more in that space.
And I think the more we look at that, the more we'll see that there's such crossover between eating disorders and autism, as we're finding with lots of presentations. So Tracey, thank you so much for providing all of us with your expertise tonight. Now, I'm aware that tonight is really a bit of a teaser, isn't it? Because there is so much to know about eating disorders. I've just shared my screen. There's a credentialing pathway for clinicians that are looking to get further expertise in eating disorders. Can you tell us more about that?
Yeah, so this is funded by the federal government. The Australia-New Zealand Academy of Eating Disorders administer this, but there's been a lot of thought in this the credentialing is available, but also training has been provided to help people get through the pathway. And the training, I've given you the relevant websites, but the training is divided into the basic stuff you need to know about an eating disorder, and then deeper dives into specific therapies, the ones that I've talked about today. And so the training is available, and there's another link to find that. So there's a lot of training happening all the time, and sometimes I appear and give that training, but not that often. So there is a definite pathway and support if people would like to develop a greater specialist skills in this area.
Great, thank you. And of course, for clinicians in Australia, you'll know that your professional development clock is ticking, and the 30th of November is the time to get all of your CPT points for the year. If you do need some more points, go to NovoPsych and have a look at all of the recorded webinars we have. Of course, this recording will be up there, as well as sessions for death anxiety, trauma, ADHD, autism, compassion focused therapy. So the QR code, if you scan that, you will get access to all of them. And if you are interested in using the ED15 through NovoPsych, do have a look at a NovoPsych account. You can use that QR code there and get access to that. Which will, I hope, contribute to the way you work with eating disorders in your practice. And for everyone who attended for this webinar, thank you for attending and committing an hour and a half of your life to serve your clients better. Obviously, we're all doing this for the service of the people that come to us seeking relief from distress. And Professor Tracey Wade, thank you again for your expertise tonight. I could see that some of the slides that you had up there, you ran through in 1 minute, but I'm sure the research on there would have taken years to compose. So thank you for giving us that rundown of your work. Take care, everyone. Bye.